Hello viewer, welcome to Brain Boosters platform. In this presentation, I'll be discussing how to use a partograph. But before I talk about how the partograph is used, I would like you to know a few things about the partograph before I demonstrate how it is used. So this is a position in which the fetus is supposed to be for normal labor to take place. This is a well flexed vertex. During labor, you are going to be carrying out an examinations or assessment of the progress of labor. And one of those assessments that you'll be carrying out is abdominal palpation, and you are going to be recording that information on a partograph. So in the first diagram here, the first image A, we have an example where the head is mobile above the symphysis pubis, and you record it as 5/5. What this means is that, is explained in B here, is that the head accommodates full width of 5 fingers above the symphysis pubis, and is demonstrated here. Okay. Then we have another example, C here, where the head is 2/5 above the symphysis pubis. What this means is that the head accommodates 2 fingers above the symphysis pubis, okay, as shown here in D. This is another illustration of how descent takes place. This is another illustration of how descent takes place. We have this dark line here, which is representing the pelvic brim. Then below the dark line is the pelvic cavity. Then above it is the abdomen, where you'll be doing the palpation from. So these images are simply showing us how the head is going to descend and what you are supposed to be recording. Okay, so 5/5 simply means the head is above the pelvic brim, and all your 5 fingers can be accommodated by the fetal head. So it simply begins to go down like that. 4/5 simply means that the head has started descending and only 5 fingers can be accommodated by the fetal head. So you go up to 0/5. What this means is that the head has descended into the pelvic cavity, and all 5 fingers cannot be accommodated by the head because you cannot feel it. It has descended into the pelvic cavity. On this slide, what we have is another illustration of descent. So another examination you'll be carrying out during labor is vaginal examination, and during vaginal examination, one of those things that you assess for is descent as well, and position of the fetal head. Now the descent that you assess through vaginal examination is recorded differently from the descent that you get during abdominal palpation. So this descent is assessed in relation to the ischiospines. As you can see, these are ischiospines. So above the level of these ischiospines, the numbers begin counting from 0, 1, 2, 3, 4 up to 5. And this is these are negative numbers, from -1, -2, -3, -5. So -5 simply tells you that the fetal head is not yet descended and is completely above the ischiospines. Then below the ischiospines, the level of the ischiospines, digits also have a positive symbol. So there is +1, +2, +3, +4. So these numbers increase as the head descends into the pelvic cavity, as this head descends down. This type of descent is usually not recorded on the partograph. This is another feature that you're going to be looking for when you're carrying out vaginal examination: how far the cervix has dilated, okay, or effaced. The first image is simply showing us how the cervix is, before descent has taken place or before it has effaced. Effacement is simply thinning of the cervix. The cervix begins to thin for dilation to take place. So in this first image A, effacement has not taken place and the length of the cervical canal is at 4 centimeters. This cervical canal, this length is this length from there up to there. It's at 4 centimeters. Then in B, we have cervix partially or partly effaced. Length of the cervix has reduced to 2 centimeters. So that's the length of the cervical canal. Then in C, the cervix is fully effaced, meaning it has thinned completely and there's no space in the between the cervical canal and the fetal head. Then in D, the cervix begins to dilate and it has dilated up to 3 centimeters. Then in E, we have the cervix dilated up to 8 centimeters. So dilation has taken place. Okay, this is important because it helps you know when to open the partograph, as you will see on the next slide. So in this slide, we have how you can diagnose the stage and phase of labor. Very, very important. This is a table. It has columns. This is our first column, our second column, our third column. So in our first column, we have symptoms and signs. These are the signs that you will use to tell what stage of labor it is and what phase is the woman is and what phase of labor it is. So the first in our first row we have cervix not dilated. So as you can see, the cervix is the one that is mainly used to determine the stages of labor. Okay, most of the times the cervix will determine when you open the partograph and usually the stages of labor. So in our first stage, in this first column, the cervix is not dilated and the stage is forced labor or not in labor at all. So the woman would be complaining of abdominal pains and all that, but the cervix is not yet dilated. And this is not a laboured phase. The second column, we have cervix dilated less than 4 centimeters. I want you to take note of this, less than 4 centimeters. This is the first stage of labor and it's in latent phase. Okay. The third column, we have the cervix dilated from 4 to 9 centimeters. The rate of dilation typically 1 centimeter per hour or more, and fetal descent begins. So the fetus has begun to descend down the birth canal. The woman is still in first stage of labor, but in active phase. So I want you to know why this is in active. Why at this stage the woman is in active phase is because the dilation of the cervix is above 4 centimeters. It's 4 centimeters and above. Okay, below 4 centimeters, meaning from 1 to 3, that's the first stage of labor, but it's in latent phase. And the partograph is usually opened when the woman is in active phase of labor. So the dilation, for you to open the partograph, the woman should be 4 centimeter dilated and above. Okay. Our fourth column is where the cervix is fully dilated at 10 centimeters, and now the woman has gone into second stage of labor. This is the early second stage of labor, the early phase, and it's non-expulsive. So it's non-expulsive because the woman has no urge to push here. Okay, the woman is going to have some contractions, of course, but these contractions are not expulsive. They are not so strong to give the woman that urge to push. So this is the second stage of labor. What is making it the second stage of labor? Because the cervix is fully dilated now. In our fifth row, we have cervix fully dilated at 10 centimeters. Presenting part of the fetus reaches the pelvis, and then the pelvis floor, and woman has the urge to push. This is the second stage of labor as well, and it's the late phase or expulsive phase. It's expulsive phase because the woman has the urge to push. She has the urge to push because of the strong contractions that they are having. So this is how you diagnose the stage and phase of labor. Now the third stage of labor begins with delivery of the baby and ends with the expulsion of the placenta. That's the third stage of labor. These are the landmarks of the fetal head that will help you determine the position of the fetus, when doing vaginal examination to see what is the position of the fetus. So these are some of the positions that the fetus may acquire or may be in during labor. So this is the pelvis and the fetal head with the landmarks. Okay, so this fetus we have is demarcated in this way. I'll do this for you to know exactly what I'm talking about. This is the right side of the woman, this is the left side, and this is the front or anterior position, the anterior side, and this is the posterior or the back side of the woman. As you can see, the sacrum is here. So this position, as you can see here, they're saying left occiput transverse, meaning the occiput, which is the landmark of the fetal head, which is this one here, is on the left side of the woman. So left occiput transverse is on the left side here. Right occiput transverse is the occiput is on the right side of the pelvis of the woman. The other one that we have is here, where the fetal position is left occiput anterior. Left occiput anterior, as you see in my first image where I distributed here, we have this part here. That's where the left occiput anterior position is, meaning the occiput of the fetal head is in the anterior side of the left side of the pelvis of the woman. It's on the anterior side, on the left side of the pelvis of the woman. Then here the occiput of the head is on the right side on the anterior part of the woman. The right side on the anterior part of the woman. Okay, that one here. Then the last one that we have here is simply saying that occiput of the fetal head is on the front part of the pelvis of the woman. So these are the positions that you have to expect, fetal head positions. On this slide, what we have are fundal contractions here, and how you chart them. So you chart these fundal contractions every half hour, which is 30 minutes, every 30 minutes during labor, and count the number of contractions in a 10-minute time period and their duration in seconds. You determine the type of a contraction by its duration in seconds, and the duration is counted from the moment you feel the contraction starts to the moment it ends. So you begin to count the number of seconds it will take for it to start and to end. So contractions that last, a contraction that lasts less than 20 seconds is called a mild type of contraction, and you have to label it as shown in this box here. So it has to be dotted as shown in this box here. Then between 20 and 40 seconds, contractions that last from 20 to 40 seconds, between these are called moderate contractions, and you have to record them using the diagonals as shown in this box. Then contractions that last more than 40 seconds, you have to record them as shown in this box. So you have to shade the whole box. Okay, so I'll show you how you record this on the Partograph. Hello guys, welcome to Brain Boosters. In this presentation, I'll be now looking at how to use a Partograph. I've already talked about the things that you need to know before you start recording a Partograph. Now here I'll be discussing how to record or fill in a partograph. Let me first of all show you the components of a partograph that you need to know. So the first part of a partograph, we have patient information. This is where you enter patient data. Above this red line I've drawn, you have to enter patient data. So this patient information is comprised of patient's name, the gravid, the para, hospital number, date and time of admission, and time of rupture of membranes or time elapsed since rupture of membranes. If rupture occurred before charting on the partograph began. So you have to record all the information in this section. Okay? Yeah, that's why you record patient information. The other part of the partograph is where you look out for the fetal well-being and you record fetal heart rate. Okay, this is also a vital part of the partograph, and this fetal heart rate is recorded every half hourly, so it's every 30 minutes you need to record the fetal heart rate. Okay, so these dark lines, they indicate the areas where you expect this fetal heart rate to be within this space. Okay, within this space. Okay, so beyond this is a great abnormality and it needs urgent intervention. Okay, the other part is the part of the amniotic fluid and the mouthing. Amniotic fluid is here you need to assess or to record the color of amniotic fluid at every vaginal examination. So you record that in this column. Okay, this is where you record the color of amniotic fluid. Now this color of amniotic fluid is recorded using you can record it using the following codes. You can use a capital letter I if membranes are intact, they are not yet ruptured. You just write a capital letter I in any box corresponding to the time you are doing your examination. Then you write a capital letter R if membranes are ruptured, or you write a capital letter C if membranes are ruptured and the amniotic fluid is clear. Then you use capital letter M if amniotic fluid is stained, is meconium stained. Then you write capital letter B if amniotic fluid is blood stained. Okay, so yeah, this data is important because it will help you know how the child is faring as well. If there's if amniotic fluid is meconium stained, that will be an indication of fetal distress. Then the other part in this row again, this is where you record mouthing. Mouthing is a situation where bones overlap, bones of the skull, of the fetal skull, fetal head, bones of the fetal head will overlap. Recording can be done in two different ways. You can use digits from 1 to 3, or you can use plus symbol. Okay, plus symbol, you can use a 1 plus, 2 plus, or 3 plus. And you record it in this same row where we have mouthing. Okay, so you record just one as a number, or you can record a plus sign. Okay, so 1 is a code that says sutures are opposed, meaning sutures are not touching, or the parietal bones are not touching each other. There is space in between them, meaning the birth canal is adequate. So mouthing helps you determine whether the birth canal is adequate or not, because there is a condition that may occur called CPD. If you don't rule this out quickly, you may end up causing injuries to the fetal skull, or the baby may not actually be born vaginally because the birth canal is small for a child to pass through. for the fetal head to pass through it. Okay, so this modeling will review, will give you a clue whether the birth canal is okay, is wide enough, or it's not wide enough. Okay, or I think that's simply one of the reasons. So you record a code 1 or just a single plus. When sutures are opposed, they are separate the space between the two bones. So or you record a symbol number 2, digit 2, or plus the plus signs, 2 of them, which indicates that sutures have overlapped but reducible. What that means is that when they are reducible, it means that when you place your finger on the overlapped bones, that overlapping is going to recede. The bones are going to slide and they will separate again because you've applied some pressure. You write a 3, or you just indicate 3 positive signs, plus signs, when sutures are overlapped and not reducible. What that means is that even if you place your finger on the overlapped bones or sutures, they will not be able to separate. Okay, meaning the fetal head could be larger than the birth canal. Alright, so that's about this part. Let me talk about the next part now. The next part of the partograph, ladies and gentlemen, we have the point where we assess, this part where we assess cervical dilation and descent of the fetal head. Cervical dilation and descent of the fetal head. So cervical dilation is assessed every time you do a vaginal examination. Okay, you assessed every time you do a vaginal examination, you need to assess cervical dilation as well. Now, this cervical dilation is the one that will determine whether to open the partograph or not. So you only open the partograph when cervical dilation is at 4 or above 4. That's when you open the partograph. And when you open, your plotting should be along, your first plotting should be along this arete line. Along this line, okay? The arete line. So for example, if cervical dilation, if it's the first time I'm doing the vaginal exam on this woman and cervical dilation is at 6, so I'll put my mark there at 6 as the point along the arete line because it's my first examination. If on my next VE vaginal exam I find that cervical dilation is at 7, then I'll record at 7. If I'm doing it every after 4 hours, I'll count 1, 2, 3, 4. So after 4 hours, it's at 7 centimeters. So it's going to be somewhere here, meaning it's going towards the action line. Okay, it will not necessarily have to be along this arete line. So what will determine my next records is the time difference and also the dilation, the amount of dilation of the cervix. Then we have another part here where we have to assess descent. Okay, so for cervical dilation, I forgot something. It's plotted by using a cross as seen here. You plot using a cross, so I'll show you how to plot. Then for descent of the fetal head, you need to plot using a 0 or an O or a circle. Okay, now this descent, as you see this line has got max. As you see, this both cervical dilation in centimeters, it has points where it's ending, and also descent also has got points where it's ending. So descent, you begin plotting at 5, ending up to 0. So this descent is assessed on abdominal palpation, and yes, that's what you'll be looking for. Okay, so on abdominal palpation, you have to assess descent of the fetal head. So I showed you earlier, I talked about how you need to assess descent on the abdomen of a woman. So you have to of course use your finger breadths, depending on how many fingers are being accommodated by the fetal skull. That's how you record your plottings. So if only 4 fingers are being accommodated by the fetal skull, you are going to record on the 4 here. If it's 3 fingers, you are going to record on the 3. If it's 2, you are going to record on the 2 here. If it's 1, you're going to record on 1. If it's 0, you're going to record on 0, meaning descent has taken place successfully and the woman might deliver anytime soon. Okay, yeah, so that's what we are going to I'll show you a scenario, and then we plot this partograph. I'm sure you appreciate it better when you see a plotted graph. Then we have another part where we indicate time here and hours. So hours simply refers to the time elapsed since onset of active phase of labor, and this can be observed or extrapolated. Okay, those are hours. So hours, you can record first hour, second hour, third hour, fourth hour, fifth hour, just like that. Okay, we can say 1, 2 hours, 3 hours, 4 hours, 5 hours, just like that. But then on time, you need to record the actual time when that examination is being done. If you are doing it at 9 a.m., you need to write your 9 a.m. here. Okay, yeah, you need to write your 9 a.m. here. Then if you are doing your vaginal exam for the first time at 9 a.m., of course you need to write your 9 a.m. there. Then you write first hour, you write your 1 hour there. Okay, then this, if you do it after 4 hours, so you count from here 1 hour, 2 hours, 3 hours, 4 hours, meaning my time, I'll record it here. Then my hours, I'll record my hours there. Okay, meaning this is how much time has elapsed from this hour to this hour. Okay, I'll show you how to record as well. Then we have another part where you need to record other stuff. Let me talk about them. Alright, so the other part of a partograph is where you record the progress of labor as well, and you record contractions. These contractions are simply they are simply recorded every 30 minutes. Okay, so you have to count the number of contractions in a 10-minute time period and their duration in seconds. So I showed you in the previous slides, in the previous presentation, how contractions are recorded. We have 3 types of contractions. They can be mild, moderate, and strong contractions. For mild contractions, they last for 20 seconds each. Then for moderate contractions, they last from 20 to 40 seconds, and for strong contractions they last more than 40 seconds. I'll show you how we shade again so that you can be acquainted with how to shade on this Partograph. And then we have so this is the part where you have to record the contractions per 10 minutes, okay, and their duration. So I'll show you how to record. Then you have this part where you have to record oxytocin given. If you give any oxytocin to the woman, you are going to record in this column how much oxytocin you have given, drops per minute. You record the amount of oxytocin per volume, IV fluids in drops per minute every 30 minutes when used. And then the next part here, this is where you have to record drugs given in IV fluids. So whatever drugs you've given, you have to record them in this column. Also, any IV fluids that you give, you record them as well in the same column. These IV fluids could be normal saline, it could be dextrose. You need to record them here. Then we have another part where you need to assess maternal well-being. So this part you need to, of course, you are looking at maternal well-being, but you're focusing on pulse and the blood pressure of a woman. So you've been shown how you need to record the blood pressure, and this is how you record the pulse. Okay, so you record them in these columns depending on the time. Of course, it has to correspond with the time when you're carrying out the examination. Okay, then we have this part for temperature. Of course, also you have to take temperature of a woman, so you record this temperature every 2 hours. Okay, every 2 hours. Sorry, I didn't mention. For pulse, you record it every 30 minutes using a dot, and the blood pressure you record every 4 hours and mark with arrows. Then for temperature, you record every 2 hours. Okay, then we have another part for urine examination. When you examine the woman's urine, this is where you are going to record proteins if you find any, ketones, and report information about it, the volume of urine that you collected, or the volume of urine that has been excreted by the woman. Okay, yeah. So this is about the Partograph, ladies and gentlemen, and the information you need to include on the Partograph. So the components of a Partograph, and I'll be discussing in detail now how you can record your data on a Partograph like this one. So now in the next presentation, I'll give you a scenario and show you how we can record this data, how we can open and close a Partograph. Thank you guys for watching. If you're not yet a subscribed member, please support me by subscribing to my channel and sharing this video to the people you feel they need to listen to this or watch this video. Thank you guys. Bye bye.